So we're going to move on to the next presentation. This is Dr. Ria Pulicharam. She is a certified investigator. She's a physician, a health economist with the National Medical Director of Population Health and Clinical Outcomes of Healthcare Partners. She's also the Chief Medical Officer of Harmonize Health, which is a platform that simplifies population health with technology. Welcome, Ria. This is a fascinating topic, and I'm going to turn it over.
Thank you. So thank you, Ruchi, for projecting the slides. So thank you for the introduction. And yes, I'm Ria Pulicharam. I will talk today about high-risk patients with multiple chronic conditions and how to reduce hospitalization for those patients. Most of the focus will be on the seniors with these high-risk chronic conditions like CHF, COPD, diabetes, hypertension, atrial fibrillation, depression, etc. So someone once told me, this is a very complex problem. So the more the complex a problem is, we need to bring simple solutions to beat it. As you can see, aging demographics in the next 4 decades, the number of seniors will more than quadruple. Next slide. So, living with chronic conditions is like piloting a small plane. So I have 2 brothers who are in aviation. And, we often discuss about pilots and doctors, and we see a lot of similarities. And one thing they told me when in 2010 really resonated with me. They said about, these large commercial plane engines are monitored from the ground when they're flying with the passengers. And I thought about it and try to see if we can incorporate technology and try to help high-risk chronic elderly patients. So for almost 20 years at Healthcare Partners, which later became DaVita and Optum, I worked with a lot of my colleagues trying to reduce hospitalization and ER visits and improve the quality of life of these patients. And initially, it was very complex. We failed miserably. We saw some luck, but then we started designing care pathways and trying to see care pathways that can intersect with multiple when these patients have multiple chronic conditions. And initially we thought, okay, I did it because I wanted to meet the metrics. And then I realized these patients are, really suffering, and how do we give them help and keep them away from the hospital? Because each time they go to the hospital, they decline in health and when they come back. So, and we can't cure them. So how do we, really prevent some of those things happening? So try to, bring evidence to some of these care pathways. And when we wanted to scale it, it was very hard. And then realized that technology is the next thing. But then in 2011, 12, I tried to introduce technology and it was overbuilt or it wasn't user friendly. So that was one of the main reasons I decided to look into more, of how to get a technology that is usable. So as you can see, we see a lot of analogy where commercial airlines have taken off with technology. There's autopiloting these days. And how do we get there? So next slide. So we all know the problem, we talk about it, but challenge really is in the execution. Next slide. So the challenges of high-risk care for these patients, the senior patients, the technology is unfamiliar, and many factors lie in it. They have multiple disease states. Unfortunately, they don't come just with one disease. And then social determinants, many of them don't have food to eat, or caregivers, or they don't have a way to get the medications refilled, or not transportation. So it really becomes a multifactorial problem. And as I said, it was very difficult to scale and we needed lots of labor. So it wasn't working well for us when we wanted to take it across different departments and states. Next slide. So the approach we took is optimizing this care delivery for outcomes. So we said, one single platform that brings all this together would be the best way to go. So like patient monitoring is important. So sensors and telehealth and optimized for the elderly patients, so it's user friendly for them. If that doesn't happen, then they won't use it, and we'll have a lot of the boxes returned to us, which was my situation earlier. And then triage and care management, because there's a lot of false alerts. A lot of patients, no matter what you tell them, they'll still take the reading with the puppy in their hand, or their granddaughter will take the reading. So we need to minimize the false alerts and help the physician with the true alerts. So guided workflow for triage, and then medication reconciliation is very important, and a lot of health coaching and diet and lifestyle counseling. And interventions, real-time intervention is important. So medication titration, there's a window of time that, a period of 3-4 days where you can titrate for a CHF patient or COPD patient, or, diabetic patient with insulin algorithm or their medication, so that they don't have to go to the hospital, right? Or platform partners with EMT visits. You could, if they're integrated, or a platform partner with food banks or caregivers, or with social workers, so we can take care of the problem in real time. Outcome optimization is very important. So the support we can give the intervening nurse practitioners or providers is very important to make that decision, so that the care pathways are optimized and automated. And then risk stratification and risk scoring, a monthly risk scoring and a baseline risk stratification, and then predictive analytics and prescriptive analytics. If you can get all this onto one platform, it becomes more simpler and easier and takes out the human error. Next slide. So what we did is we said, okay, this is very good in principle. How do we really show that it can work? And we started seeing some good results, and we said, let's try to prove it. And we decided to do a study called Project Trident, and we got IRB approval. And the primary objective was to reduce hospital admissions, hospital readmissions, ER visits. And secondary objective is to see quality of life and physician and patient satisfaction. Next slide. And so, like I said, IRB approved study, it's a 12-month-long pilot. The criteria was 4 or more comorbidities and 1 hospitalization at least within the past year. 1,200 patients, 600 patients on the intervention arm and 600 on the control arm. And matched cohorts, because we didn't want anyone to say that, we were cherry picking the patients. So matched on age, sex, and comorbid conditions. And we gave them the 600 on harmonized platform, we gave them Bluetooth-enabled sensors. Next slide. And they were randomized. So what we found is we saw that after 9 months, we saw 61% reduction in hospitalization, which was unheard of, and 41% reduction in ER visits, and $7,000 per patient per year savings. We also found that there was 50% reduction in bed days, which showed that we weren't just masking hospitalization, we were also keeping the patients healthier. 30% reduction in hemoglobin A1C. Some of these patients had hemoglobin A1C like 13 and 12. So we brought it down below 9, like 8.5, and still going down. And we're trying, the data is trending in the right direction. It'll finish by the end of the year, and we plan to publish. We also brought 40% to goal on blood pressure values of these patients, and 50% plus showed improvement in the quality of their life and patient satisfaction, including we also measured physician satisfaction. Next slide. So I want to share an example of a typical patient. For example, there's a patient in Apple Valley that's on our platform, age 69, with AFib, CHF, and diabetes, and also depression, which is now mentioned here. And this patient, before the patient came on our platform, the doctor was like, this patient's blood sugar used to run really high and really low. Already this year, he was in the hospital 5 times, and he has no teeth, and he couldn't chew food, so he was just drinking Coke or soda, and he hadn't filled. We did medication reconciliation, so when we brought him onto a platform, he was alerting left and right. And we did our medication reconciliation. We found he hadn't filled his antidepressant for 3 months. So we made sure that he had somebody, take it to his home, drop it at home, and also worked with his care management team and got him a dentist appointment, got him some dentures, gave him we integrate with food banks. We got him the proper food and diet and lifestyle counseling and really coaching him. Look at the value. It has gone down, and his hemoglobin A1C from 13 is at 9.5, and it's still improving. So we wanted to show that, it's really comprehensive care. So we can't really fragment that care when we deal with these patients. Next slide. So one thing I want to say is the Harmonize platform is a very intelligent platform, and it's important, and we are getting end-to-end data and closed loop data so that you can see initially when we started, the false alerts were so many, it's being reduced and equaling with the interventions, or the interventions are even increasing because the platform itself brings up important issues. Next slide.
Please, I think your time is you can just continue, but
yeah, okay. So, I just want to show the risk scoring that we do dependent on patient alerts, compliance. The monthly risk scoring really shows how hospitalization is reduced because we can predict hospitalization. Next slide. So this is just showing the, how we stratify the baseline risk and where the patients are, we want to get them to moderate high. Next slide. So this is an example of how the patients come in and see how they're in high risk with their vitals and non-adherence, and how we try to reduce it and bring it more towards, in 1 month itself, you can see a significant reduction. Next slide. So this is something I just want to end with, the only thing worse than being blind is having sight but no vision. So I'm sorry I went over time, but it's difficult to bring everything in 10 minutes. But I hope that was helpful.
Now that was wonderful. I mean, that is an amazing platform. I mean, just thinking about chronic care. So I have a lot of questions, but one of the things that I wanted to start with was that, so your point of care, you're bringing point of care into the homes with these patients. Are you doing any of this also in assisted livings, in chronic care facilities, where now moving those patients to the hospital is really such a high risk?
Yes, so right now we started working with risk-bearing entities, and then it grew from there. They didn't even wait for the study to end. So we're working with a number of risk-bearing entities, and they're also interested in taking it to assisted living and other organizations that are taking care of high-risk patients. So this tool is for anybody that is taking care of high-risk patients because it's very comprehensive with social determinants and all aspects of taking care of this patient in real time.
It's terrific. Did you have any, you talked about the reduction in hospitalizations. And the false alerts were much lower with Harmonize. You did have a control with that as well. Those weren't false negatives.
No, we had a control in the study.
Okay. Yeah.
Yes, we had a control arm of patients with standard of care.
Gotcha.
Yes. So it was 1-to-1. Yeah,
it was 1-to-1. Yeah, because the graph was fabulous. I mean, like, wow, the bar graph got so low, but the first thought is, are we underdiagnosing? But no, that's terrific. So we have some questions in the chat room. One of them is, are any of your providers trained in palliative care?
Yes, we are now starting to go into palliative care organizations, as well as we are taking care of palliative care patients. Yes,
that's. Okay, terrific. And will the payer be the patient? This is the $1 million question. Who do you think is going to pay for this?
So right now, the risk-bearing entities have high-risk patients, and that's their biggest risk. So they're the ones who are paying for it. But the future, I've had lots of patients who are in our program call us and say, hey, can my friend be in this program? I'm doing so much better. And so we've now thought about even offering it to people whose plans are not paying for it. But right now, it's really the organizations that are capitated or risk-bearing entities or the payers.
So what is your business model?
The business model right now is with, a PMPM for this. Anywhere between $30 to $90. And risk-bearing entities are paying a PMPM for their patients because they have high-risk patients. So that's the business model now, depending on what do is it the device, just the platform, or the alert triage folks, like the pharmacists and the nurses and, the medical assistants, health coaches, dietitian, or if you want the physician and the nurse practitioners also to intervene.
This is terrific. This is really amazing, Ria. Thank you so much for doing what you're doing and help making us learn all of these amazing things that you're doing. There